Gallo. I first met Rob when he was my intern on the medicine service years ago, and he was a very bright, very focused individual. Did not know that he would end up doing an informatics fellowship, though. But tell us a little bit more about yourself, Dr. Gallo. Where were you born? Where did you grow up? Was this what you thought you'd end up doing with your life? I don't think it was. So how did you end up here?
Yeah, so I'm actually from not too far from here. I'm from Modesto, California, which is in the Central Valley, kind of the farming region of California. And went to undergrad and med school in St. Louis, Missouri. So in the Midwest for a while before coming to Stanford for residency. And yeah, I really wasn't thinking about research. You know, in undergrad, I did some kind of wet lab work that I really didn't like, or just didn't motivate me to really want to pursue research long term. And it wasn't until being in the hospital, seeing patients, coming across countless questions that really we just didn't have good evidence for, and I felt really compelled that I wanted to try to generate evidence to help my practice, help other people's practice. And so the more patients I saw, the more I thought, wow, I actually really, one of the things I really find stimulating is research questions, coming up with them and working on projects. And so it was partway through, I would say, my residency that I thought, okay, well, I should actually explore this further and take some time to do that, which you really can't do during your clinical training. So I decided to try to find an opportunity that would let me. So I found this opportunity at the Palo Alto VA and as a medical informatics research fellow. So it's pretty broad, but kind of overall able to tackle some of the questions that I see in the hospital.
I can see you're not computation for computation's sake, but you're really using informatics methodology to answer important clinical questions and driving decision making in a way. I see the key theme, and I can see you've also been very invested in learning methodology at a deep level, much more than I see many others want to. So I think it's been very cool to see your progress. And why don't you go ahead and take it away? We're very much looking forward to this is now published work right now. Yeah, like very recently a pretty high impact paper in JAMA Internal Medicine. So take it away.
Yeah, great. Well, yeah, thanks so much for having me. Really happy to be able to share with you all my research projects. So I'll be talking about a topic that touches on some of the things I was just talking about. A topic that I saw a lot in my clinical training, which is I found both very helpful, but also kind of pretty tiresome, actually, frankly, and that's clinical decisions. And so for those of you that don't know, physicians, they're kind of constantly being bombarded by notifications, alerts, telling them, watch out for this, you need to focus on this. And really, there's just not enough time to devote, your attention to everything you wish you could. And you do have to prioritize and deprioritize things. And so, these kind of, some of these alerts and notifications can be pretty simple things like notifying you that a patient has a medication allergy, don't order this medication. Or this drug interacts with that drug, you should be careful. To more kind of complex, maybe output from prediction models like early warning systems that I'm gonna be talking about today. And, this tension, like I was talking about earlier, this tension that I felt between I wanted evidence that the things I was doing was helping patients, especially things that I found personally kind of, maybe a little, I felt the burden of all these alerts coming at me. And so that really motivated me to try to look at this question and prove that these alerts, these models are actually helping patients. Like Jonathan just mentioned, this will follow a recent paper of mine that was published in JAMA Internal Medicine. There's a QR code for anyone that's interested that has a link to the paper. But essentially what we'll talk about is the topic of clinical deterioration during hospitalization, why that's important, what prediction models have been developed to try to help with this problem. And mainly we'll focus on Epic's model and how it was implemented at Stanford Hospital. And I'll spend most of my time talking about how we evaluated the model's effect on patient outcomes. And I use a specific method called regression discontinuity design that we'll talk more about. I kind of have to give a disclosure that my views don't necessarily represent the views of the VA, where I'm a medical informatics fellow in the US government. But I don't really have any other disclosures. I do want to make sure that I thank and acknowledge the team that made all this work possible. So there was a whole team that really worked hard on implementing the model at Stanford. Ron Lee and Lisa Shea were physician leads on that effort. Margaret Smith and her team at Stanford Heart, kind of an applied AI operations team, was also involved, was also very instrumental. And then some nursing informatics colleagues that helped out. And then I had several methodology mentors that I'd like to acknowledge, including Pascal Geldsetzer and Ben Marafino. Okay, so clinical deterioration. Physicians care for many sick patients concurrently. Sometimes it can be up to 20 or more in a hospital. As a resident, I frequently was taking care sometimes of 20 patients in a day, some coming and going. And by definition, these patients are sick. They're admitted to a hospital because they need constant monitoring potentially, and they need that hospital level of care. And so because of the number of patients, it can be difficult to actually really for a physician to monitor them all and know what's happening with a patient at a given time. And that makes it easy for physicians to potentially miss some early warning signs that a patient's actually getting worse or, as we're calling it, deteriorating. This is important because deterioration is associated with significant morbidity. It can increase hospital stays. Patients may have to go to an intensive care unit with all kinds of interventions, and they may have many different complications, including even mortality. And so this, begs the natural question: if we could predict which patients were going to deteriorate, and if we could get that information to their doctors and medical team, could we prevent deterioration, which could have a big impact? And so many people have been working on this and developed prediction models for this question. I think these have started to evolve now that they've been integrated into electronic health records, where instead of someone kind of manually checking vitals and all kinds of things, a lot of these can be automatically pushed to a model in real time, and then the output from the model can be sent to the physician or the medical team in real time. And so even some of the EHR vendors have started to get into this game of making their own models. And so Epic Systems, one of the most common EHRs in the US, accounting for over a third of hospitals. And if you look at larger hospitals, it's more like 60%, including Stanford. They've developed their own prediction model. This has been pretty widely implemented. A couple of years ago, Epic was really saying, oh, this has been implemented at hundreds of hospitals, with Stanford being one of them. And so, I think it's, wow, it's being used at hundreds of hospitals. It must be good, right? Well, I don't know that we actually really know that. There's pretty limited evidence regarding any of these models' effectiveness. The only randomized trial that's I found looked at a very old model. It was a single center study, and there was no real difference. So, I don't know that we know for sure that these models are beneficial unless we study that. And there's really been no reported randomized trial of the Epic model, despite its use in hundreds of hospitals, as they said. And there's probably a number of reasons for this. I think it's partly technical limitations on the hospital side of randomizing patients and setting up the logistical support. Cost is certainly an issue. But I think it's even sometimes people aren't sure if there's clinical equipoise. They just assume these models will help. At the same time, I think there's actually some real potential for harm. I mentioned earlier kind of my experience as a resident being bombarded with different alerts and notifications, and I think there's a real risk of alert fatigue. And so really, I think we all want to be convinced that this is actually helping patients if we're going to put this burden on physicians. And so the objective of the study was to determine the effect of the model's implementation on patient outcomes at Stanford Hospital. I'm not going to get too much into how the model was kind of validated or implemented, but a little bit more information about the model. It's proprietary. Epic actually doesn't release a lot of the information publicly, so the model's functional form and its parameters are actually, I don't think, public information. They do say that it's a ordinal logistic regression model that they used machine learning to make. And they tell you the predictors that go into it. It's a number of laboratory data, flow sheet, kind of nursing input data, and vital signs. And then the outcomes it's meant to predict are kind of a composite of different things, including patients having to be transferred to the intensive care unit, have a rapid response team activated, which is a form of kind of emergency support team that if a patient's getting worse, a nurse or a physician can basically call for immediate help. Many hospitals across the country have these teams. And then cardiac arrest and death. And the score outputs the model outputs a risk score that ranges from 0 to 100, higher scores, higher risk. That's the idea. The model was validated at Stanford. Ron Lee and his team did the work on this. I wasn't actually involved in this, but AUC, I'm sure many people are curious about, was 0.7. And I guess the implementation team decided that a score of 65 would be the threshold at which patients would be kind of categorized as high risk. And this was mainly, I think, based off of kind of capacity and resource constraints with the hospital. And at that score, they found a positive predictive value of 0.2, which, I think many people might think is kind of low, actually. So the model was piloted across 4 units over 2021. And remember, this is kind of during the time of COVID. So a lot of things are changing and happening during this time. As part of the implementation, there was kind of a pathway associated with the model where the team was notified. They were told to evaluate the patient, talk about reasons for potential deterioration, but no specific intervention was necessarily required. So the model is being implemented. How do we actually evaluate that it's effective? The gold standard is usually a randomized controlled trial. I already mentioned some of the kind of reasons why that's not often done. In this case, I think the hospital decided that logistically it wouldn't be feasible. And so they said that wasn't really an option. And so what often happens is people will do what's called a before versus after study, just look at outcomes for patients hospitalized before it was implemented and compare it to patients after. I think this kind of study design is pretty tough because a lot of things change besides just implementing the model. And I mentioned that this was during COVID, so things were changing month to month, week to week, sometimes day to day. And so it's pretty hard to say that's a real apples to apples comparison. And so what I instead did was use what's called a regression discontinuity design, which I'll tell you more about. So RDDs, as they're called, they utilize arbitrary thresholds in a continuous variable as a form of natural experiment. So you can imagine we make decisions all the time based on some arbitrary threshold, like a risk score of 65, like I mentioned. And so patients below that score don't receive the intervention, patients above do. And so if you're looking at the figure here, there's on the x-axis, there's some continuous variable, let's say a risk score. And the y-axis is the probability of receiving treatment. And so as you're kind of going across the x-axis, you see almost no patients get the intervention, you hit the threshold, and then 100% of patients do. But if you zoom in right around that threshold, patients right there in the narrow window you would expect to be very similar. So a patient with a score of 39.9 versus a score of 40.0, essentially the same. And you can think of even random error and however this is calculated as shifting patients to one side or the other, forming a pseudo randomization. And so then, because these patients just on either side are pseudo randomized, we can look for a change in outcomes right at the threshold. And so I did that using the threshold for the Epic Deterioration Index at Stanford Hospital. So we used the maximum risk score during hospitalization. And you can see on the figure as you go to the right, very few patients receive treatment, that's the y-axis, to nearly 100% receiving treatment at the threshold of 65. It's not completely deterministic because there's some exclusion criteria, one of the most notable being comfort care. orders, because it just wouldn't be appropriate to do all these things for those patients. And so those, as you go farther and farther right, there's more and more patients that are comfort care because they're sicker. And then
You also spelled out what that it means with 9.8 doctor.
yeah, comfort care is essentially when patients say, you know, I don't necessarily want to focus on doing everything possible to save my life. I'd rather focus on making sure I'm comfortable, and that may mean that, you know, I pass naturally if it's my time. And so it wouldn't be appropriate to do all these things for those patients. So the outcome we looked at was escalations in care, which we defined as rapid response team activation, intensive care unit transfers, and cardiac arrest. The type of regression discontinuity we used is called the local linear regression. I won't get too much into the details of that, except to say that basically you're saying, okay, we want to look at a narrow window around the threshold, because as you get farther and farther, the patients become less and less similar. And so it doesn't make as much sense to include patients that are farther away. And there's ways to kind of come up with this optimal window that you look at. In this case, it was 7 points on either side of the threshold. This is somewhat arbitrary, so we vary that to check sensitivity to that choice. And so of 10,000 admissions during the time period we looked at, there was about 1,000 patients within that window. And so this is the results. For the primary outcome, there was a absolute risk reduction of 10%. And so when you're looking at the figure here, scores increase as you go to the right on the x-axis. And so you can see that the y-axis is event rate. The event rate increases as you go to the right until you reach a score of 65, and then there's a drop. And so because the only thing that we think is changing across that threshold is the treatment, that difference there, right at the threshold, is the treatment effect we're estimating. And like I mentioned, we check sensitivity to that choice of window around the threshold. And really we see consistent estimates of improved outcomes across bandwidth choices. Although as you get to really wide bandwidths or windows, the confidence intervals start to include the null, probably because you're including more confounding. We also did, we wanted to make sure this wasn't an artifact, so we actually did a placebo test using patients prior to the implementation, as well as on units that weren't part of the pilot. And these are patients that aren't receiving the intervention, so we wouldn't expect to see the same effect, which we don't. There's a couple of assumptions to mention. One is that people aren't manipulating this risk score, because then it wouldn't truly be pseudo-randomized if people could choose, oh, this patient I'll push to one side or the other of the threshold. What we do is we look for signs of bunching that indicates that would indicate there's been manipulation. So we look graphically as well as empirically, and we don't find any evidence of that. Another assumption is that the only thing changing as you cross the threshold is the treatment. And so we wouldn't expect confounders to change. And so we looked at a couple, one being age, the other being Elix-Hauser comorbidity index, basically a summary of how sick patients are. And we don't see any significant difference, any evidence of a significant difference. So overall, we found that the EDI, this model, when it was implemented, was associated with a decreased risk of escalations in care for patients near the threshold used during the implementation. And while this is retrospective, the RDD analysis supports that it actually is a causal effect that we're observing. And multiple checks for validity seem consistent with the necessary assumptions of this model or this method. There's definitely some limitations I should note. One being that, this is still retrospective. There's still some opportunities for bias. It has more assumptions than a randomized trial. Also, we use the maximum risk score rather than the full dynamic range of predictions. And so that probably reduced our power. And also these results don't necessarily apply to patients that are farther from this threshold, because we're really estimating that treatment effect right at the threshold. Still, I think this is important because it's really the only evidence of effectiveness we have to date for this model. Despite its widespread use, I mean, if you were to count the number of patients this model has touched in some way, I think it would be very, very large. I do want to mention that Margaret Smith and her team at Hart are doing some work to try to figure out, okay, well, what's the mediator of any improved outcomes we see? And also the flip side, what's the effect on the medical team? Potentially alert fatigue, what they find helpful, what they don't, things like that. And so, before I stop, I'll leave up here a few concluding thoughts. One is that, it seemed like the implementation did reduce the risk of escalations in care in these pilot units, and it's since been rolled out. This model has been rolled out to other units as well. And then, another, I think, point I'd like to make is regression discontinuity designs have a lot of potential to be used in situations where a randomized trial may not be feasible. And I think this is really promising for quality improvement projects because they're often, done as kind of just pre-post, before after studies. And, it's hard to know if it's truly the intervention that made a difference or not. So this is a potential alternative for many models. Also, if you're kind of transporting a model that's been shown to be effective somewhere else to your own setting, this could be, kind of a simple way to, or an easy way to evaluate that it's effective in your setting as well. So I put another link to the paper, to my paper, as well as some contact information if anyone wants to connect. Well, great. I'd love to take any questions if we have a little bit of time.
Yep. All right, great. Thanks so much, Dr. Gallo. Well, the question online from Ashish, he had a follow-up earlier. Generally, you were involved in this decision. The question is how do you ensure false positives don't overwhelm the systems? Basically, that threshold, the 0.65, where did that number come from? And how do they, PPV 20%, they didn't want 100%, they didn't want 1%. How does anybody even try to figure out the right number for that?
Yeah, I mean, it's a really great question. And I think, you could imagine an alternate universe where a different threshold was chosen, and maybe that would completely change the results. Maybe it overburdens people too much if you made it lower, and doctors just completely, or doctors, nurses completely ignore the notifications. I think that's very possible. Like many of these models when they're implemented, it's basically just someone estimates what they think the hospital can handle. And talks with the clinical teams affected. So that's my understanding of what happened. They said, okay, we expect X number of alerts, a unit a day. Is that too many? And I think that's kind of, how they chose 65. There's a little more information in the paper I cited from Ron Lee and his team. So it's tiny, but it's this paper in NEJM Catalysts at the bottom where I think they talk more about how they came up with, the number and how it was implemented.
Actually, Ron, you can talk if you want to comment on, I see you made a comment on Rob's work, but also on that question or anything else.
Yeah, sure. Thanks. And yeah, thanks Rob for such an outstanding job here. So just to answer the question about the cutoff and false positives. So first of all, to Rob's point, as you can see, a PPV of 0.2 is not great. I mean, this is just what we had. I think it's important to note that it's much lower than the advertised quote unquote accuracy that Epic had advertised because of the validation that we did on our data, as well as the outcome and the constraints around the validation that we thought was clinically relevant. That being said, 1 in 5 is actually not terrible. I mean, if you're asking a doctor and a nurse, if your patient has a 1 in 5 chance of getting really sick and needing to go to the ICU, should you talk to each other? The answer is usually yes. And that's actually how we sold it to the teams. In fact, I think when we implemented this, the way we were able to do it successfully was specifically to not call it an AI project. It was just, we want to improve communication between nurses and doctors. And look, if there's a patient who has a 1 in 5 chance of getting sick, would you want to do it? And I also unanimously everyone said yes. And the 55 was just basically, that was actually the cutoff that yielded the highest PPV. So that's how we chose it. And just real quick on this comment I made, one thing that we are actually seeing that I think is really exciting is this second order effect of implementing the model. I mean, the direct intervention, as Rob mentioned, was this huddle. But I think what we're seeing is just this culture like nurses in general are more attentive to sick patients. They're more empowered to reach out. And all of that I think is probably mediating the effect. And I think in general for like technology and AI, like this is the kind of stuff we see as what's important to design into the system.
Great. I'm gonna start having April start plugging in, but we can squeeze in maybe one or two more questions, I think.
Yeah.
There's a she's been asking several of you questions. Do you want to ask your question directly, or otherwise I can ask for you?
Yeah. Hi. Great talk. So my question was, I'm more from a computational background, but really excited about this area. So let's say that you deploy this, it works great for the time being. So you need to put in some monitoring plumbing, right, to ensure that, let's say, the patient population that Stanford or the unit sees evolves over time, right? Or the kind of patient that gets referred to the unit changes over time. So how do you watch out for these distribution shifts and monitoring over time? Thanks.
Yeah, I think that's a really great point. And actually, I think that's one of the strengths of this statistical method. You know, so if you were to do a randomized trial, after the trial is over, you have no idea what happens afterwards because you're not randomizing anymore. You could, I guess, you know, try to track patient outcomes, but you have no comparison. Versus an RDD, you could just keep checking the same analysis at different times and see if you still get the same results because you have that built-in comparator of the patients below the threshold that don't receive the intervention. So I actually think, you know, there's been some people raising problems with model drift over time and how that can be for a number of reasons. Maybe patients change, maybe our interventions are so effective that the old predictors aren't predictors anymore because we've solved the problem. We don't really know. And so I think a regression discontinuity design is actually nice because you have this built-in comparator that should always be there theoretically.
Very much compared to like a rules-based alert, it's hard to do discontinuity, right? Because it's very discrete. You're really taking advantage. A lot of the machine learning models come up with a risk score, right? This continuum, which you're able to exploit here, which is a good opportunity. I don't know if you answered this, but going forward, should we just always just do RDDs for any kind of these types of risk score things, or should we still try to do an actual RCT?
Yeah, you know, I think I maybe touched on this a little bit and kind of the limitations. You know, this is still a retrospective evaluation. So there's still some room, I think, for biases to be introduced or confounding. You know, it also requires a large number of patients because you're only
This little bandwidth, right? You're looking at.
You're looking at, you know, I think essentially a tenth of the patients were included in this analysis. So that's a real limitation. I think the nice thing is if you don't have the capabilities for randomization, maybe you're a community hospital or this is just a question that you think this is going to work. So you don't want to spend, you know, sometimes randomized trials are millions of dollars.
Yeah.
You don't want to spend that money. I think, you know, those are probably the situations where this would be helpful.
Great. And last touch comments, otherwise I hope people can reach out to for discussion afterwards, just like Dr. Gallo. And then turn it over to Dr. April Liang, one of our clinical informatics fellows. Before we dive in, tell us about yourself. Where were you born? Where did you grow up? How'd you end up in this crazy place?
Sounds great. Hi, everyone. My name is April Liang. I'm a first-year clinical informatics fellow. I actually didn't know I was going to be a doctor either. In fact, I resisted being a doctor because my mom told me I would be a good one. So of course, in my classic adolescent mood, I was like, absolutely not. I'm going to do other things. But then in college, I, you know, really loved direct community service and seeing direct impact. I hated the wait time to affect and impact for traditional benchside research. And I really still loved biology and the sciences. So I was like, my mom's right. And it was the hardest thing I had to admit to myself up till then. But then the other serendipitous thing is that in college, I also took an introduction to computer science class at Princeton. And I was, you know, awed and shocked and also fell in love with that. And so I had to then revise my life plan again and say, okay, maybe I'm going to major in this. And so I graduated from Princeton with a degree in computer science, went on to medical school, But then as I was finishing that, I was like, well, I don't want to let that fall to the wayside and waste all my, experiences and knowledge in that. So how do I really combine the two? And that's what drew me to the field of clinical informatics. And that's how I'm here now. As a clinical informatics fellow. So I have a background in internal medicine. So my focus is in hospitalized patients. But in our informatics field, we have the privilege of, seeing a lot of different fields. And today I'll be actually touching on 2 projects that have nothing to do with hospital medicine or internal medicine at all. So again, I'm really honored to be here today to present my work, and I will be talking about 2 quite different projects evaluating and applying for in the healthcare setting. And just an outline of our talk today. So the first project I will talk about is actually using GPT-4 to detect when guardians or parents are accessing adolescent patient portal accounts. Number 2, we'll be talking about the pre-charting use case for GPT-4 using new ENT, so ear, nose, throat referral appointments. And then finally, I wanted to save some time with specific questions I wanted to poll you all about, but also open up for greater discussion. And even though I have time set aside for discussion and questions, please feel free to interrupt me at any point and ask your questions. So without further ado, I will now tell you guys about the first project, which is using GPT-4 to detect guardian access of adolescent patient portals. I know not everyone here is a doctor, and probably even fewer of you are pediatricians, so we'll do a quick crash course. The takeaway is that adolescent health confidentiality is really complex. So on one hand, adolescents are legally considered minors in most cases, and so their parents are or their legal representative and can, on their behalf, kind of make decisions for them. And adolescents can assent, but consent really comes from the adult. On the other hand, adolescents also warrant a degree of privacy and confidentiality protection, just like all patients are afforded. So this real tension is borne out in our regulations as well. On one hand, we have the recent 21st Century Cures Act, which mandates electronic health data access for patients and their legal representatives, meaning, patients and their legal representatives deserve a certain level of transparency to their own health data. On the other hand, we have laws like HIPAA and minor consent laws, which vary by state, that then enforce confidentiality. So what does that mean? It means that depending on the state, for example, in California, these are actually all the types of services that adolescents and minors can consent to without necessarily their parents' knowledge or input. And as you can see in many cases, physicians are actually prohibited from sharing those details without the adolescent's consent. So how then do we ensure health information transparency on one hand and adolescent confidentiality on another? So one potential solution was the idea of proxy portal accounts. So I don't know how many of you have a MyChart or MyHealth, but essentially patient electronic portals are a very nice window into our own health data. And there are different levels of patient portals, kind of account types that allow differential access to what information can be seen. So for the same patient, when the patient themselves log in, they can see a certain, set of data. But when their parents log in through a proxy account, they see a different set of data. And this very colorful but convoluted graph actually shows what Stanford Children's Hospital does currently with their MyChart. As you can see in this box for adolescents, there's actually quite a big difference in terms of the different levels of access and accounts provided. So this all sounds really great, and proxy accounts are maybe the solution to this issue of transparency versus adolescent confidentiality. Or is it? Unfortunately, the truth isn't so optimistic. In fact, a couple of years ago, right here at Stanford Children's, one of the clinical informatics fellow who was a pediatrician actually looked into this exact issue of, are proxy accounts actually being used appropriately? So what they did is that they actually developed a natural language processing algorithm to determine, based on the types of the messages that were being sent from patient accounts, whether the adolescent patient wrote it or whether it was probably a parent or guardian writing it. So the natural language processing algorithm looked at whether, the message contained references like my son or my child, or named the patient in third person, or if the signature matched one of the guardians on file. So using this pretty simple rules-based NLP algorithm, they actually applied it and looked into messages sent from adolescent portals at 3 different hospitals, or 3 different pediatric health systems, Nationwide, Brady's, and Stanford Children's. And there were many notable findings. So first, as you can see here, that just activation of proxy accounts is pretty low overall. So adoption is pretty low. But one could argue, maybe only patients are accessing it and parents don't actually care. So then we use the NLP to look at the messages being sent. And as you can see in this graph, actually, especially as with younger age, more and more accounts showed evidence of parental involvement and messaging directly. And finally, that overall, an estimated 64 to 76% of adolescent accounts were actually being directly accessed by their parent or guardian based on the message content analysis. So this obviously poses a challenge to ensuring adolescent confidentiality. Yes?
This is without consent.
So we don't know with or without consent whether the adolescent patient themselves said, here mom, take my password, that's fine. But I think the institution policy is that because there's the potential for sensitive data sharing, that we would want parents, even with permission, to use the proxy account to access. So that's totally a good point, that we don't know if these are secretive, surreptitious parent access, or if it's the children's okay with it. But overall, our goal is still to have appropriate utilization of proxy accounts, just to prevent inadvertent data kind of spillage. Okay, so, but that was helpful because the NLP algorithm can then be used to help us figure this out and, warn us when this is happening, right? But the NLP algorithm does have its flaws. So it really helped characterize the scope of the problem, but I was actually imperfect in solving it. So it had pretty low sensitivity, as you can see here, which means that not all accounts being accessed by the parent or guardian are being flagged. And that is still a potential risk for confidential data being inappropriately shared. Additionally, because of the way it was set up, the NLP algorithm really is not well integrated in the current workflow. So what actually happened was that it became this utility that was batched, run a couple of times on thousands of accounts manually. And then those accounts that were flagged were then sent to the help desk, and they had to do outreach to be hey, parent, maybe consider using the proxy account instead. So it's really unwieldy, and we have actually not been continuing to use this utility since its development 2 years ago. So with the rise of generative AI and ChatGPT in particular, a natural question then was, can GPT actually do better in helping us solve this problem? So in our project, we basically developed a study to evaluate GPT-4's performance in this task. We had a collection of 2,100 manually labeled messages from our institution from 200 unique adolescent patients, and 2 pediatricians had manually labeled them for the likely authorship, whether it was an adolescent patient or the guardian or parent. And as you can see at baseline ground truth, more than 70% of messages were labeled as being authored by a proxy. So then we actually took a stratified random sample of 20 messages in order to do prompt engineering on, and actually had 2 prompts developed, which I'll delve into later. But after the prompt engineering step, both prompts actually had perfect performance on the 20 training messages, so to speak. So essentially the 2 prompts we then developed were, the 2 types of prompts we developed were single task and multitask. And what that means is the single task prompt really only asks GPT, hey, who wrote this message, the parent or the adolescent? And the multitask GPT prompt really looks ahead and thinking about how do we actually integrate this meaningfully in a clinical workflow. right now Epic actually has an integrated GPT-4 capability embedded in the in-basket, which is how patient portal messages are displayed to clinicians. And so it'd be great if we could kind of fold that in, and in addition to GPT-4 providing a draft to apply to the patient's inquiry using that integrated tool, we also have it at the same time say, hey, we noticed that you're writing on behalf of your child. Can you call our help desk to get a proxy account instead? And so that multitask GPT was really looking ahead in terms of how do we practically implement this. So multitask asked, hey, respond to the patient's inquiry and tell us who wrote the original message.
I had a quick question.
Yes.
How are you determining the ground truth? Is it the two pediatricians who manually determine ground truth?
Correct. So two pediatricians basically read the message, and I think they had access to the patient's name. And I think it's also the parent or the list of guardians. And then they said, patient, not patient, patient, not patient.
Okay, thanks.
And then there were two of them, and so they had reached consensus. And I think the kappa was 93%.
Oh, well.
Okay, so now on to our results. So there's a lot of numbers on here, but what you can probably see is that GPT-4 actually had dramatic improvements in sensitivity and predictive value beyond NLP, significantly. GPT did, both prompts did have lower specificity than NLP. However, due to the high prevalence of, parent guardian messages in our population, that did not translate to a huge decrease in the positive predictive value, and it was still over 95% in both cases. And then reassuringly, there was no statistically significant difference in performance between the single task and the multitask prompts. So that was good to see that, this idea of cognitive burden only applies to humans and not to GPT. So the conclusions from this particular project are that GPT-4 has excellent sensitivity and specificity for detecting when guardians are authoring messages and achieves greater than 95% PPV and NPV on our specific population at Children's. That multitask GPT-4 does not suffer loss of performance, and so that provides an easy way for us to plug into the existing augmented response technology that Epic is actually already piloting here at Children's and on the adult side. We can just add a piece of the prompt and say, hey, in addition to writing back to the patient, can you also tell us can you also determine if it's the parent? And if it is the parent, send them a little blurb saying, hey, here's how you contact our help desk to learn more about getting a proxy account. And then finally, that even though we focus so much on adolescent health and privacy concerns, these have really broad applications in terms of patient confidentiality, especially in geriatric patients and individuals who have developmental differences and may need legal proxies. I'll take a pause here.
I don't know if you showed it, what was the prompt? You just say, hey, GPT-4, is there an adult in here or is there not? I mean, or you have to give examples or?
Yeah, the prompt is very unwieldy, so I did not put it in here. But essentially it was pretty generic and said, looking at the message content and tone, is the writer a parent, or is it the adolescent?
Examples, or is it just described in detail? Do it have to go through 20 iterations?
So I think it was maybe 2 or 3 iterations to achieve the 100% sensitivity and specificity. We do give certain examples, almost similar to what the MLP did, being things that might tip you off are my child or my son or third person references. In the prompt engineering, we did notice that it sometimes had challenges with third person, then because if people said we or our, then it would get confused and want to classify that as proxy when it didn't necessarily mean that. But
kind of also interesting that within all the prior NLP work wasn't totally wasted, because a lot of the terms that were defined there could be used here to help train GPT-4 to know what to look for, I guess.
Yeah.
Cool. Other thoughts, questions? Otherwise, we're about to move to, you're gonna talk about a different project,
yes.
I usually think an unwieldy prompt is maybe bad for us to look at, it's good for the model.
Yeah.
The more very detailed prompt.
Yeah.
I love to see.
Actually, the single task prompt is probably small enough to share, and I'm happy to maybe include that in future iterations, but the multitask prompt is definitely unwieldy because like it talks about, how to respond to the actual message content, right? And it's like, oh, if this, then that, if like it's very.
So some chain of thought.
Yeah, exactly. That's what we also found, like some chain of thought helped.
It's like, let alone programming language, it's like magical incantation, like this magic spell, and you have to say this like phrase, and we're trying to get this object to behave in a certain way is what it's turning to.
And it might change its mind.
Yeah.
I had another question. I was just wondering, so you use GPT-4. I was just wondering, any thought about comparing performance of GPT-4 versus other LLMs like Mixtral or Llama 2?
Not in our particular study, and part of that is because ours has a real implementation focus, and the current implemented LLM that is readily available through Epic is GPT-4, and so for that reason, we wanted something that was actually like feasible, now.
Yeah, ironically, one of the best ones is the one that's easier to implement, strangely, and this is the opposite for a lot of research settings. And just because I don't know anyone totally knows it, can you just spell out the in-basket augmented response, like what that is?
Yeah, sure. So as I mentioned, so patients can send their provider messages on MyChart through their portal, and that's what we were analyzing the content for. But, after physicians receive that, they probably have to read it and respond to it. And so on the physician side, in the electronic health record, we basically think of it as your like email in basket, but only from patient messages. And so every day, a lot of our jobs, especially, outpatient providers, they are looking through those, responding appropriately and sending messages back to patients being like, hey, thanks for letting me know, I gave you the refill, or, that ankle sprain doesn't sound too bad. I don't think you need an x-ray, but let me know if it's worse in 2 days. So there's a lot of back and forth, and actually I'll talk about documentation burden a little bit in the next project, but it's a huge time sink and actually uncompensated work for physicians to be doing this in-basket response to patients. And so a lot of that has translated into burnout and after hours, pajama time is what we call it. So one of the AI solutions has been Epic actually integrated with OpenAI and GPT and said, hey, we can ask GPT to read the patient's in-basket message and draft a response for you. And as a clinician, you can either say, oh, that looks great, send that directly, or, like add your signature and send it, or you can say, I don't like this draft, I want to do my own. But this is actually in production at children's and adult right now. And so that's why it's an easy way for us to like basically slip this in if the performance was promising.
Great, well, let's go to the next one because I'm sure we'll have more follow-up there.
Yeah. So the next project is looking at pre-charting for using GPT-4 in new specialty referrals. And if you're wondering, what is pre-charting? What is this made up word? It is actually a type of documentation that we clinicians do. So documentation is unfortunately a core and necessary part of healthcare. It serves many important purposes, such as reminding yourself about what you talked about with a patient, for billing purposes, a legal record of patient's care, and more importantly, also communicating with other clinicians who might be seeing the same patient. So one of these things is pre-charting, and think of this as collecting and synthesizing all the information that you feel is relevant to you before you see the patient in order to kind of form a preliminary understanding of who this patient is and what they're coming in to see you for. However, multiple studies have also shown that EHRs have paradoxically increased documentation burden and contributed to clinician burnout. And pre-charting is definitely no exception to this rule. It is better characterized, I would think, as an unnecessarily complicated evil rather than just a necessary evil. So the current state of pre-charting in the EHR is, think of it as a time-consuming scavenger hunt. So it requires multiple clicks navigating across different parts of the chart. As you can see here, the chart review menu offers you a variety, dizzying array of options, from notes to procedures to the labs to radiology reports. And as the provider is seeing a patient, you're probably clicking through all of those in order to find the things that you want to know. Additionally, you are probably unlucky enough to have a 24-page fax scanned document that you then have to also look through to make sure there wasn't anything really important hidden there. And then all this work in order to generate like 3 or 4 sentences that says, here's a high level overview of what the patient has gone through, why they're here now, and probably what I think is going on. So we have done studies about pre-charting and time spent in charts also, and for PCPs, we know spend almost 6 hours in the EHR per day of work, and 32% of that is in this chart review activity. ENT doctors, and I'll get into ENT a little bit later, but ear, nose, throat doctors spend 57% of their total EHR time in their clinical review and note writing. So this is a very time consuming and, like I said, unnecessarily complicated process. So it should come as no surprise, especially in this talk. The next question was, can GPT-4 help us? So we basically collaborated with champions from the ear, nose, throat department here at Stanford and narrowed in on doing a feasibility demonstration for using GPT-4 to do this pre-charting. And specifically, we looked at only referrals that came from within Stanford Health. So Stanford Health providers referring to Stanford Health ear, nose, throat providers, focusing in on nasal congestion as the reason for the referral. And there were 3 clinical champions working with us on this in terms of participating and reviewing the pre-charting. And we looked at a 6-week period. The output structure is we have a list of 6 kind of questions here. 4 of them were yes, no, and kind of no mention questions around symptomatology and history. And 2 questions were more focused on summarize the prior imaging results and summarize the prior ENT notes. To actually enable this technologically, we also built a pre-charting pipeline that leverages GPT-4. And several design decisions were made in the process about, how do we deal with context limits? How do we summarize our summarize notes in order to get under the context limit? What things do we look at? What note types? What is our time frame, et cetera? So there was a lot of iterative, design involved. But today I'm not going to focus on the technical aspect as much and share with you the results from our 6-week pilot with the 3 ENT physicians. So over this 6-week time period, we were able to pre-chart on 25 unique patients that met our inclusion criteria. And of those, based on those, we actually were able to solicit feedback. We got 12 responses from ENT physicians who were scheduled to see the patients, and then 23 additional feedback was kind of done by myself and another internal medicine doctor looking at the pre-charting notes as well and rating them. So we had asked everyone, based on for each individual question, what they're feeling about the question's quality was, or the response quality was. And as you can see here, the majority of questions achieved ratings of average ratings of 4 stars or more. However, kind of the summarization tasks still have a little bit of a ways to go, with averages slightly below 4. And then the kind of bigger question we also asked was, will people actually use this? Is this actually helpful? And 69% of all users said that they would use or would use the summary with edits. And then 49% agreed or strongly agreed that the provided kind of yes, no questions and output saved time. So the important and large looming limitations of this are that it's a very small sample size and that the ENT physicians' feedback rate was only 50%, which is actually pretty good for physicians, but obviously limited. And then currently, because of the pilot infrastructure, we were limited to a manual non-EHR integrated workflow. So that increased the burden on our participating clinicians in order to give us that feedback and ingest those inputs. And then this group probably doesn't know what Care Everywhere is, but I'll just summarize and say that our tool could only look at internal notes and documents. And if anyone was coming from outside or had data from other institutions, we could not see those. So even if they had a CT of their sinuses at UCSF, we could not look at those results in our model pipeline. So
Is that because of limitations on Care Everywhere side? Like they say you're not allowed to, or just the technology can't do that yet?
Maybe both.
Yeah.
And some would seem like technical barrier, just finding the right pipes to hook up, and then it sounds like Care Everywhere, you're not supposed to mass download other hospitals' data.
Yeah,
It's
because Care
supposed-
Everywhere data actually lives and belongs to the other institution. Care Everywhere like provides you the window into the other institution, like gets the feed, but it doesn't actually stay in your system, is my understanding. And so that data technically doesn't live in our database locally.
TBD. Users
Yeah.
definitely have said multiple times that's what they actually want, and it's not even clear technical or policy wise where it's possible, but we're figuring it out.
Okay. Oh, it's a mess.
Hey, back when I was a resident, you had to e-fax somebody to get a fax back. It's already better than it was.
That's true, except we still have faxes, as we saw with the 24-page,
Yes.
fax summary. So as I promised, I actually have some questions on behalf of our study team and would love to hear your guys' thoughts, especially from your medical informatics research background. If you have ideas on what measures, in addition of or in place of the ones that we used to evaluate the pre-charting output. Number two, what are really meaningful thresholds for deciding whether this utility is worthwhile to pursue and like build more broadly? And then number three, kind of related to that threshold, like what is the burden of evidence that you feel is needed to reach that decision? Meaning like sample size, like how many patient summaries do we need? How many ENT feedbacks do we need kind of to help us get there? I can go
I
back
had a
to,
question.
yeah,
I was wondering, in terms of time saving, right? You had this number that 49% felt that it saved them time. I was just curious that in terms of actual deployment in a like eventual real world deployment, GPT-4 generates a summary, pre-chart summary, and does like before it actually goes into the system, is it meant to be completely autonomous, or will there be a human ENT attending who reviews the document? Because if there's going to be the human in the loop, then it's actually increasing work, right? The attending has to read the GPT-4 summary and then kind of compute the human summary and see if there is a concordance, fairly high concordance between the two. So I was just curious if you and Jonathan had thoughts on that.
yeah, I think that's a really fair point. So as you may have seen from the adult side in basket pilot, so actually what I was just talking about where GPT drafts a response to the patient's messages, their outcomes show that there was no change in time saved. But people mentioned like, or like qualitatively, there was some trend towards or there was a change in perceived cognitive burden. And so there's this idea that even if you don't save time, like is needing to think less or do less of the clicking around hunting for it meaningful in and of itself. But yes, the intention is that an ENT physician has to check this because this is going into the patient's legal record. And we know that GPT-4's like summaries does still have errors and suffers from hallucinations or missingness. So that is also kind of part of how do we balance like the helpfulness with we know that it has limitations and errors.
This is a tough follow-up question, but if it was 99% accurate, you wouldn't care. You would just automate this. Why would I bother to double check basically at that point? I could just ask the patient. But it's like, hey, you just did that adult adolescent thing. That was like 95% sensitivity, especially GPT-4 is like magic. How come it's like not magic here? Why is it different, you think?
Yeah, I think the nature of the task is first of all very different. One is like very almost like classification, and traditional machine learning probably could have just done fine too. Like NLP didn't do terribly. Like look at the sensitivity on NLP. It was like 99%. Yeah,
Yeah.
something was very high on NLP. I'm forgetting now. So I think the nature of the task is very different, and then we also ask it to only output yes or no, and so it's very limited in terms of its kind of like solution based. Whereas this one is asking GPT-4 to be much more, I think, creative in terms of like it needs to generate summaries based on a lot of information that it's getting. So I think the nature of the task is just so different.
I think what was also a challenge here was it's not just, do you think this note says something? It's like, here's a whole medical chart. It's not even clear if any notes are relevant. And that's been a challenging information
Right,
retrieval
exactly.
task that won't even fit in the context window necessarily.
Right, exactly.
Let's give it a Vishala Mishra, do you want to ask a question?
Yes.
And then we'll
Yes,
start
thank you.
closing.
Can you hear me?
Yes, go ahead.
Yes. Okay. So I was curious about so the numbers showed that say 69% would use it, and I'm wondering if you looked into the effect of the summarization task and perhaps if that played a role. Also, if you can talk about the metrics that were used to assess the fidelity of the summarization task, and perhaps some qualitative aspects that you also assess, like, you know, was there adequate coverage of, say, the lab and imaging? Did that say maybe play a role in like the average rating? The imaging summary has a lower rating. Somehow I just noticed on the figure that you have on the slide. And then the other question I had was the summary repetitive in any sense, or do you see adequate coverage across everything that it had to summarize? I hope that question was clear.
I will try my best to answer the different components. First, just to clarify the structure of the output a little bit more. We actually did not ask GPT-4 to package the whole thing into a summary. We asked it to say, yes, there was nasal congestion. Yes, there was intranasal steroids used. Yes, there was facial pain. And then ultimately it would say ENT notes, none found, like if they had never seen an ENT. And if there was imaging, it would say, oh, you know, imaging had shown blah, 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 blah. And it would summarize that. So ultimately it was not a kind of ready to use summary, because we know that physicians often have strong preferences for the formatting and structure of their pre-charting. And so we didn't want to impose that unnecessarily on everyone. So instead we kind of were focused on providing the crucial pieces of information that they can then weave together in the format that they wanted. In terms of the summarization task specifically, in terms of then fidelity. So in the survey, I did not present that yet because we haven't had a chance to analyze all of this. We did also ask the providers, were there any errors and was there anything missing? And so we do have data in terms of the human responses on that, because like I said, the ENT doctors were still in the loop and doing their own pre-charting and confirming what the output had shown. So we do have that, but we're in the process of looking through that. And then finally, for the summarization tasks, as someone who like reviewed a lot of the output, I will say I noticed some like deficiencies in the summarizations for sure, especially related to imaging. It often actually would not include normal findings. So even if someone had a CT of their head and their sinuses said, you know, normal sinuses, that negative finding is actually kind of important if you're seeing someone for nose stuff and turns out to have nothing on their CT to be worried about. But GPT-4 would consistently, I think, not include those. And so there's almost this imbalance of like, you know, ignoring negative or benign findings. So I think that is just a trend that I noticed.
Awesome. Maybe we're kind of at time, so if you want to maybe just give a last word, or a follow-up question, just afterward will be okay. Any last thoughts or?
No, I just wanted to make sure I had time to acknowledge everyone who's helped me. Big teams here, takes a village, and then some references, but yes, here's my contact, and yes.
All right, Kenny, well, we thank both of our fellows for a great discussion. For Q&A for anybody who'd like to follow up. Great, thanks everybody, we'll catch up soon. Next week.